The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the AHRQ PBRN webinar on electronic health record functionality needed to better support primary care. I would like to briefly review the agenda for this webinar. First, I will explain how to submit a question to our presenters. Then, Dr. David Myers from the Agency for Healthcare Research and Quality will introduce today's first presenter. Dr. Alex Krist will then give a presentation on EHR functionality needed to better support primary care, and we will have our first question and answer session after this presentation. Dr. Myers will then introduce our next presenters, who are representatives from 3 primary care organizations. After their presentations, we will have our second question and answer session. Please note that after today's webinar, a copy of the presentation slides will be emailed to all webinar participants. If at any point during this webinar you have trouble hearing our presenters, please try hanging up the call and dialing back into the webinar. I will now explain how to submit a question to today's presenters. To submit a question, you may use the GoToWebinar control panel. Type a question under the Questions section and hit Send, as shown in the screenshot on this slide. You may submit a question at any time throughout the presentation. During the Q&A sessions, as time allows, your questions will be read out loud and our presenters will respond. I will now turn the presentation over to Dr. David Myers.
Once he comes off mute. Good afternoon, everybody, and thank you so much for joining today's webinar. It is a pleasure on behalf of AHRQ to welcome you all today, and specifically from our PBRN program. I'm very sorry that our PBRN initiative lead, Ms. Rebecca Roper, isn't able to be here herself to welcome you. It's really due to her efforts of pulling together many streams of work that this webinar is being made available to you. I also want to start by continue by thanking Kristen Milkowski, who you just heard from, who is one of the great folks at AHRQ's PBRN Resource Center, who helps us organize not only these talks, but are working continuously to provide materials so that America's primary care PBRNs can be more effective and efficient in the important work that they're doing. Today's call, because of the important topic that we'll be discussing, has been opened up so many of you may not be associated with primary care PBRN. If you want to learn more about them, you'll see some information on the final slide, or you can visit them at pbrn.arq.gov. On to today's call, I'm thrilled that Alex Krist has joined us to talk about some of the work he's been doing, not only in PBRNs, he is a true PBRN researcher, but in a larger community of primary care researchers. Dr. Krist is the co-director of the Virginia Ambulatory Care Outcomes Research Network. The network is a community of practice throughout the state of Virginia dedicated to collaborative research to better understand and improve primary care. He's also a faculty member of the VCU Family Medicine Residency Program at Fairfax Family Practice Center, where he sees patients and precepts medical students and residents. His areas of research interest include integrating clinical and community care systems, patient-centered care, informatics, and medical decision-making. As an expert, he regularly advocates for the primary care community's needs with federal policymakers. He received his MD degree from the University of Virginia in Charlottesville, VA, and his MPH from Johns Hopkins University in Baltimore, Maryland. Alex, take it away.
Thanks, David. I appreciate the opportunity to talk here today. So, all right, I'm going to transition things over to my screen to control the slides here. The framework for what we're going to be talking about is a paper that we recently published in the Journal of the American Medical Informatics Association. It came out in January of this year. It was really aimed at trying to develop a primary care perspective on and a primary care roadmap on where to be moving forward with the development and implementation and use of electronic health records. And while I'm going to begin this presentation and talk about the paper content and the conclusions and some of the details, it really represents a collaborative effort from lots of individuals. So here's a list of some of the co-authors, but this was also developed in collaboration with the American Academy of Family Physicians, American Board of Family Medicine, American Academy of Pediatrics, and the North American Primary Care Research Group, and then a number of members, actually 48 members of the North American Primary Care Research Group, Health Information Technology Committee, all participated in developing this. So while I'll be talking, this is the work of many people here. As a little bit of background, the NAPCRG, Health Information Technology Working Group, it's one of 6 working groups that was assembled in 2005 by the Committee for Advancing the Science of Family Medicine. There's an economics group, a research methods group, a membership group, a practice-based research group, and an education group. The HIT committee at the time, or currently, has 43 members. It represents perspectives from the United States, from Canada, and the United Kingdom. And while some of the things that we're talking about today with respect to meaningful use don't apply as much to Canada and UK, their experiences were shared in developing this. And there are 38 different universities and primary care organizations, and then part of the process in developing the content here was that we vetted this with a number of different clinicians, HIT developers, informaticists across 4 of the practice-based research networks to vet the content and make sure that what we were saying was correct and accurate from their real-world working perspectives. So over the years, the HIT working group has met fairly regularly. I've been a part of it since 2005, and they've undertaken a number of different projects. At the beginning, they talked a lot about data architecture needs and how do we design electronic health record databases so that they can be used for research. There was a lot of interest, particularly among some of the folks with more of a clinical background, about how do we use electronic health records to better support practice workflow. More recently, there was this interest about reframing meaningful use and using it as a theoretical model for trying to say, how can we make information systems better support primary care? That's what we're going to be talking about today. We also submitted what we talked about today in January of 2013 when the Office of the National Coordinator was looking for public input to frame phase 3 or stage 3 of meaningful use. We wanted to make the content of our recommendations useful for that body. So, and now there's a lot of interest in continuing to think about how do we use our electronic health records for research, for better practice redesign, for increasing patient access to their data. And the patient access to data is something that the group's been very interested on and working on for the future. So the theoretical framework that we're going to talk about here today that kind of led to some of the recommendations, it started with a number of the different members coming together from the practice-based research networks talking about the troubles that they were having with using their electronic health records, both for doing research and for carrying out care. And a lot of the different difficulties that people would describe were kind of all over the board. And so we were looking for a way to say, how do we kind of categorize this and make sense of it and systematically say, what should our roadmap be of where we're heading forward and where we're making our advancements? And so that was the idea behind this. And what the group decided to do was to say, let's use the Institute of Medicine's definition of what primary care is and what primary care does, and use that as a basis to say that electronic health records should support that functionality. And then the group said, let's use stage 2 meaningful use objectives to define what electronic health records can currently do. So that second part of an assumption with that theoretical framework has obvious limitations. So electronic health records can do a lot of things that aren't mandated through meaningful use. But meaningful use creates a really nice roadmap of what basic functionality within electronic health records should be. So among the group that was participating, they felt that that was a really good framework for kind of objectively saying what can electronic health records currently do and what are they working towards doing, because a lot of health records might be able to meet stage 2 criteria or stage 1 criteria, but they're still developing functionality to meet stage 2 criteria. So what the group did is they went through and they looked at all the objectives that already exist and they categorized them to each primary care attribute. And that was done to try and say, well, how well is that attribute met? So once they were all categorized, the group looked at the objectives that were supporting that attribute and then used their primary care perspectives to say, cross-reference that with the IOM definition of what should be occurring and say, well, what other supports and tools and resources do we need? And then collectively the group had an iterative process to come up with some of these recommendations. And as I said, once the recommendations were framed, we went back to the 4 primary care organizations to get their input. We went back to the different members of the HIT committee, and then we went to 148 clinicians and informaticists within the practice-based research networks to get further input and directions. So delving right into this now, thinking about the primary care attributes, the Institute of Medicine defines 7 different attributes. And this model was Jim Mould. He'll talk later on the call about this. So Jim framed this very nicely in these categorizations from the entire IOM report, which is rather lengthy. But the first one of the attributes is accessible. And the IOM defines this both in terms of patients being able to have a primary care clinician and being able to receive care when they need it and when it's convenient. So that's how it's accessible is defined. Coordinated refers to care is coordinated across services and across settings. It's proactively provided based on all information available. It's done in the right sequence, and it's appropriately using existing resources. IOM defines sustained care as providing longitudinal care over a patient's lifetime, and as opposed to thinking about single encounter focus or an isolated exchange. And it's thinking about continuous care for events occurring in multiple settings over a period of time. The comprehensive definition means that primary care needs to address the entire scope of services. It needs to address prevention, chronic care, acute care, mental health, needs to occur at any stage of a person's life, and it needs to occur in any setting where they might need care, such as an office, a home, the emergency room, a hospital, or a nursing home. The partnership with patient definition focuses on the therapeutic alliance and the relationship-based approach to care, and to advocate for patients and guide patients through the healthcare system. And then seeking agreements between clinicians and patients on health goals and account for individual values and preferences that patients might have when defining and deciding on care options. And the IOM defines person-centered care as addressing the whole person delivered in the context of family, so thinking of living conditions, family dynamics, cultural background, and the community. And the community serves as a context for identity. It's also a source for social and psychological support, and it determines the patient's environment. And then the last element that the IOM defines is integrated, and that refers to creating a system that allows all primary care attributes to function within practices across the entire care delivery system and throughout the community population. One of the nice things about the IOM definition of primary care and thinking about these attributes is there's strong correlations with this to the patient-centered home home model that many groups are working on. So if electronic health records can support these different attributes, they're probably supporting the patient-centered medical home. Many of these different attributes are also needed in specialty care and potentially in inpatient care as well. And this also fits with directions of accountable care organizations and some of the healthcare redesign that's occurring these days. So the next activity that the group did after getting consensus on the different definitions was to go through and map out each meaningful use objective to just one attribute. And as I said, there's some limitations with doing this, and one of the limitations is meaningful use attributes weren't designed around the primary care needs. And in addition to that, some of these attributes might actually support more than one primary care need. But we focused on putting each attribute under one primary care definition. So when thinking about accessible care, the current meaningful use objectives, the groups felt like secure messaging supported that. For coordinated care, the group felt like the meaningful objectives of the physician order entry, e-prescribing, patient summaries for transitions of care, the ability to view, download, and transmit information all supported coordinated care. For sustained care, the group felt like the meaningful use objectives of patient reminders, and one patient list for outreach was a registry around one diagnosis and such, all supported sustained care. Comprehensive care, there were many elements that were parts of comprehensive care, such as recording vitals and smoking status, medicine reconciliation, lab results coming in as structured care or data, and access to imaging results were all felt to support comprehensive care. And for patient partnership, the meaningful use objectives of providing after-visit patient summaries, patient-specific education resources, and recording advanced directives were felt to support the IOM definition of patient partnership. And then patient-centered care was supported by the meaningful use objectives of recording demographics and recording family history. And integrated care was supported by the objectives of 5 clinical decision rules, submitting to immunization registries, public health agencies, and cancer registries, and then protecting health information. So one of the things that, after the group went through this exercise, that sort of became apparent is the holes that potentially exist in filling these different attributes. So we're going to move next to talking about what holes to fill these attributes. And Kristen, if you can post the first poll question to the group. We wanted to make this talk a little bit more interactive today. And so to start with, we wanted to ask everyone on the call their opinion on which primary care attributes, based on the description of it and what meaningful use is filling with it, do you think electronic health records currently need to make the most improvements? We're only able to have 5 responses, so we lumped comprehensive and sustained care together, and we lumped patient partnerships together. We'll give one moment here, and then we'll close out this poll. Great. It looks like a lot of folks are thinking that some areas that we need to do some of the most work are around coordinated care, but close behind that is integrated and patient partnership and comprehensive care, and accessibility had the lower number. So then the next question we want to ask before moving on with some of the specific recommendations is the second poll question, which is, which primary care attribute do you think that electronic health records currently best support? And once again, the same categories of accessibility, coordinated care, comprehensive or sustained care, patient partnership or person-centered care, and then integrated care. Great. This mimics a lot of the last question. The areas, it seems like the group feels like electronic health records are doing better around accessibility and comprehensive or sustained care. And that's interesting. The NAPCRG HIT group had thought that meaningful use had a bigger focus around promoting integrated and coordinated care with the stage 2, the stage 1 focusing on data capture and sharing and other types of information. But all of the areas were things that folks thought that there were places to make advances. So now going through, I want to take a moment and talk about some of the gaps that our process identified where we need to think about where to move forward in the future. And a couple of things about these gaps that are important. So to one extent, this can sort of feel like a wish list, and it's not meant to be and feel like a wish list. It's meant to be more of a roadmap for activities. And the other thing is there's been lots of advances within electronic health records over the last decade. We've made gigantic advances, and some of the issues have to do with functionality, and some have to do with implementation, and some have to do with policy. So there's lots of rooms for different improvements. For the primary care need around promoting accessibility. The holes that the process identified that they thought needed better support to help primary care. One was around making documenting, accessing, and conveying information easier and less labor-intensive. This is an interesting topic. It came up a lot for discussion on where does this go about making documentation easier. The reason the group thought this was an issue around accessibility is because the group wanted to take clinicians out of the role of doing data entry and wanted to make them more there and available to be with the patient and interact with the patient and to have visits, and that would promote accessibility. Some other things came up as well, such as supporting enhanced asynchronous care. The secure messaging is one of the meaningful use objectives, and that's a great start in this process. But to support accessibility on another level, everyone felt like there were opportunities for virtual visits, for texting, for really promoting care outside of traditional office visits. And then a common theme that came up was not just having functionality in the electronic health record that could promote these primary care attributes, but also having functionality embedded that could kind of automate some of the tracking and monitoring of how folks are doing. So around accessibility, a lot of practices do a lot of effort to calculate time to third next visit or other things that might be a way that they could monitor their accessibility. But this is something that could be automated through the electronic health record process. Additionally, there could be things that could promote the relationships around this. Moving on next to the topic of coordination, the issue of receiving and aggregating information came up commonly, and the group felt it was really important for clinicians at the point of care to be able to receive and aggregate information so that they could know what was happening in other settings and other environments outside of their information silo. Another big theme that came up among primary care is that folks are working to do team-based care. It's a big movement at the moment to try and expand access and to have other care providers involved. But the electronic health record doesn't necessarily support that coordination, both internally and externally. So linking into ancillary and enabling services and community resources was important. Being able to define roles and track progression, and being able to have an environment where everyone can communicate around what is happening within patients was felt to be very important to promote care coordination. And then another theme that came up was this idea about, instead of electronic health records just being a source to enter and store information, to move to the next step of being able to synthesize and prioritize information, both for an individual patient and a panel of patients. This would greatly help coordination. So if the systems could identify and sequence visits linked to changes and results, spanned across settings, and then highlight population urgent messages, alerts, and changes, that this would be a real needed advancement to promote coordination. Around sustained care, the group talked about better mechanisms to track and support continuity of care. And this was an interesting thing that came up from our reviewers around the article. The process identified allowing patients to identify who their primary care provider was and being able to track and manage panel size. And we had a little pushback from some of the reviewers who had some concerns about patients being able to define primary care providers and primary care providers being able to limit panel size. But without being able to do this, clinicians can't be around to take care of their patients over time for sustained periods. And then being able to track and support care over the time period so that we're switching from these episodes of care, like what we have with ICD-9, to being able to describe chronic conditions and how it evolves and changes over time. And Bob Phillips is going to talk a little bit more about that later when we get to his section. The other area around comprehensiveness, the electronic health records are promoting a lot of this, but particularly in primary care, a key challenge is we've got to address the whole spectrum of care, so prevention, chronic, acute, and mental health. So the example where this comes in the meaningful use objectives, you have to have 5 decision supports and alerts, and that's a great start, but having 5 doesn't support the whole spectrum of care. And then seamlessly being able to support across settings, and a new direction that people thought we needed to think a lot about was ensuring the accuracy of the information that's in electronic health records. A lot of things we're seeing more and more within practices, that the information that's being stored or that might be coming into the record can be misentered. And how do we improve this process? And one of the mechanisms for thinking about this was engaging patients in the process, and even thinking about alerts and reminders to try and auto-resolve outdated information or to identify data inconsistencies, because a lot of times within the same record, there's things that don't make sense. The partnership for patients, this was an area that on the poll you all identified as being more well done, which I think is many aspects of this are moving forward. Certainly stage 2 meaningful use is promoting engaging patients and their families. The partnership for patients, the gap that the group identified was trying to incorporate more perspectives into electronic health records. This is a big issue right now. Medicare is trying to promote this, and there's some PCORI RFPs around trying to incorporate patient-reported outcomes and patient perspectives into electronic health records. I think this is an important area. Also trying to support the decision-making process, both in terms of who makes decisions, how are they made, and then providing the tailored educational material. The educational material is part of meaningful use stage 2, but some of the processes aren't there as much. From a person-centered standpoint, some of the gaps that were identified were around supporting whole person care, and in the primary care setting, what that meant was thinking less about the disease focus. It's pretty easy to enter and record disease information, but more defining who patients are as a person. So meaningfully recording things like their family history and values and important life events and other things to clue the care coordination team in for a patient as to what might matter for patients would be an important part of patient-centered care. And then going back to that definition, patient-centered care talks a lot about the environment and community health factors. So being able to bridge primary care with public health in the community, which is a big movement in the IOM these days, is also an important functionality that needs to be built out within the electronic health records. The integrated component of or definition of primary care was a little more nebulous for figuring out sort of what that meant and what some of the functionality was that needed to go in there. But from creating an integrated standpoint, one of the big themes that came out was trying to be able to use electronic health records to support national health recommendations and priorities. So when we have guidelines, when the Surgeon General and others identify priorities, how can this be more integrated into the electronic health records to allow the clinicians and allow on a national level for us to sort of pursue a direction to promote better health on a population level. That was a common theme that came up as being very important. And at the same time, another important factor is that among practices in different settings, there's different needs among patients and practices. And so while there needed to be some of that national standardization, how can content be locally tailored to suit those specific needs of different environments in different settings? And then tying into integrated, as we're making movements towards accountable care organizations and thinking about population management, how do we build that into our systems into a way where we can track between population measures to actually delivering care to individuals? So not just the dashboard and the performance measures, but then being able to drill down to actually delivering care as in response to this. And then how does the system promote accountability for care? So some of the elements for doing that would be capturing important health outcomes, things like morbidity and mortality and the patient-reported outcomes, and then collaboratively sharing this direction in a bidirectional manner with public health partners who can help individual practices with tracking outcomes and how their populations for care are doing. Okay, so we had wanted to stop with another poll question really quick, and the poll question that we had was, what new function would you most like added to your electronic health record? There are lots of different functions that could be added to this electronic health record, but we wanted to see what the group thought would be most important. So we are talking about aggregating data from multiple sources at the point of care so that it could be used in care delivery and coordinating care, the team support, defining the roles, the dashboard to synthesize and prioritize information, incorporating patient perspectives into electronic health records, and providing enhanced population management. Great. Well, that's a great response. So it looks like it's divided up in thirds around option 1, 3, and 5. So, all right. One of the other things the group talked about as well is not just thinking about the electronic health record functionality, but thinking about how do we implement and use this functionality. And the group was thinking about this from the practice level. Having the ability to do something in an electronic health record is very important, but if it's not used, it's not going to have the intended effects. So the group thought a lot about, from a practice level and a health system level, how do we sort of assess where we're at with things? And the group came up with 4 phases. A first phase is the technical part of making sure that the electronic health record has that functionality. The second phase was making sure that the practice decides to turn on and use that functionality, and then begin to get their practice members to understand how to use it in a meaningful way. And then the third phase is actually using the functionality as part of care, and hopefully that leads to the 4th phase where we have improved outcomes. But part of that whole cycle is that as practices adopt and implement things, and as they start using things, they need to be going through and tracking and assessing metrics and process and what's happening. And then they also need to be tracking about whether it has the intended improved outcomes that everyone is hoping, and then go back and reassess that functionality, and if it's not improving the outcomes that we're intending, how do we change the functionality and move to the next level and make it better? So we had a quick poll question here for the group. If you're a clinician in a practice, what phase do you think your practice is at? If you're not a clinician in a practice, what phase do you think most practices are at with implementing electronic health record functionality? Great. It looks like majority of people say they think their practice or practices are at phase 2, which is, if we think about the meaningful use roadmap, the stage 3 of meaningful use is focused on improved outcomes, which would be phase 4 on this. And it looks like most of us don't think we're quite at phase 4 yet. But this is a continuous ongoing pathway, and the positive end both for practices as well as researchers and informatics developers is there's lots of other things that we can do to make our systems better. So from the model that we used to try and come up with some of these recommendations and think of this as a roadmap on things that we should be working on, both in terms of adding new electronic health record functionality as well as implementing, as well as policy to support this, it does have limitations. As I said at the beginning, electronic health records have functionality not mandated by meaningful use. Meaningful use wasn't designed necessarily to support the primary care objectives, so they don't neatly fit into the attributes, although it provided us a useful model for thinking about more objectively things that we needed to work on. And a lot of the recommendations aren't prescriptively detailed. We didn't go through and say, very specific things that necessarily needed to be changed. And some of that's because we really need a lot of innovative interventions to try and think about this, and there probably needs to be multiple ways to address this. And a gap in functionality doesn't necessarily mean that adding that functionality is going to improve outcomes. That goes back to that cycle, and part of what many of us think of as PDSA cycles. Part of it is thinking about making these changes and seeing what happens and objectively measuring and tracking changes over time. So, overall the group felt like while there's lots of advancements in functionality and implementation, more work is needed. And some of the areas that were important to think about would be care coordination, relationship support, and whole person care. As we identified with the polls here, I think it supports a lot of these recommendations. And some of those solutions require functional changes in the technology, standardization, new infrastructure on a national level, thinking about the financial models and policy changes. So it kind of leads into one of the last poll questions that we have. And in the open part for questions for the group, Kevin Pierce had asked about how does meaningful use force EHR, how much does meaningful use force electronic health record use in the right direction, and Susan Miller had asked how do we overcome the problems resulting from a marketplace approach to developing the electronic health record. So we actually wanted to poll the group and find out what the group thought was the best way to promote advancement of functionality. We identified 5 ways, and we're not saying that they're not all important. All of these probably are important ways. But one is mandating changes through EHR certification. The second is incentive changes through meaningful use payments to clinicians. The third is lobbying vendors or policymakers to make changes. That's partly what our group was trying to do, and partly why we tried to get all the primary care organizations involved. Another approach could be to let the free market drive electronic health record changes, or looking for new technology leaders to create something completely different. Great. So it looks like the group, the #1 response is around mandating changes through the certification process, but that's really closely followed behind meaningful use, which is good because that's a lot of the policy directions that we've been undertaking on a national level. There does seem to be some interest in both lobbying the existing vendors and approaching new technology leaders. And as I said, probably all of these different approaches are necessary if we really want to advance our systems as much as we're hoping to. David, I think now is the time that we had set aside for questions.
Yes, and thank you so much, Alex. It's an amazing presentation, and I'm going to have to go back and read your paper again and again to get all of this out of it, though I know I'll be able to read your slides again when we post them online. I want to thank all the people who've already started submitting questions. We've got some good ones, and we'll probably have time for a few more if people still have some. But let me start. So you, Alex, concluded that innovation is one of the things that's needed here. We've got lots of innovators on the phone and in the PBRN community. So I want to start off with if people themselves want to solve these problems, do you have any suggestions to them about where researchers in PBRN should be looking for funding to move forward the needed research and innovation?
Oh, I think that's a great question. I think that there's a lot of interest in making some of these advances. So I think that there's a lot of different approaches that people can take to support funding. There are also some challenges from a funding perspective, but obviously AHRQ is a fabulous place to go for funding. You have the whole health information technology portfolio, so that's an excellent mechanism for thinking about studying and getting support for studying this. I mean, there are among other funding agencies, certainly groups like PCORI are very interested in injecting the patient voice into our electronic health records and into that electronic care delivery process. Many of the NIH institutions have a dissemination and implementation funding mechanisms, which can be a nice way to find funding for things. On a different level, though, what I think is also interesting is that many practices and many health systems are making changes and doing innovations on their own. Many health systems have to design and modify and change their portals and their electronic health records. So there are opportunities for thinking about building research and innovation into some of the clinical activities that are going on. And quite honestly, if you think about the amount that these clinical systems are investing in creating and buying these systems, adding a small amount of funding to do some research to measure outcomes is not an unreasonable request. So I think that there are some traditional and some other interesting funding mechanisms people can think about for supporting some of these innovations.
Many thanks. I'm going to quickly answer a question myself. Rob Gray asked, is there work underway to collect and or test best practices of workflow in primary care, including some researchy questions? And anybody who's interested in workflow in primary care, and especially the integration of health IT into workflow to improve quality, I encourage you to visit healthit.arc.gov. We have a small portfolio of work in that area and a toolkit that's designed for understanding issues around that part. And if others have ideas, feel free to send them in. Alex, another one for you. Folks have been asking, wow, an amazing list, but probably too big to be tackled all at once. So do you have suggestions about how this community can help prioritize that list? We saw you did one poll question, and that was great. But how do we go deeper and help inform funders like AHRQ? What are the most pressing issues to tackle first? Any suggestions?
Yeah, and it is a long list, and it's not meant to be something that everything needs to be done and addressed and tackled at once. It's just not possible. And that's one of the reasons that we've framed it a number of times sort of as a roadmap. And it's an iterative, ongoing process, and that was the purpose of pulling this together. What we started to do for thinking about developing this as well as prioritizing this was really engaging the end users. So that was where we reached out to the different clinicians and the folks implementing the systems within our practices. And they're not hesitant to provide their opinions and their perspectives. I know within our practice-based research network, we're also engaging patients. So I think that the end users, in terms of clinicians and patients, I think that they have some strong needs in figuring out how to prioritize things. The other thing, too, just from a very simple perspective, getting into the different settings where things are being used and watching and seeing what's happening and thinking about human factors analyses and engineering, it's pretty easy to identify a couple of things that are areas to prioritize. I think one trap we sometimes fall into is we often prioritize based on what's feasible, and so sometimes I'll hear folks say, well, that's really great, we need to work on it, but it's really hard to do that right now. We do have to try and bite off some of the hard things as well long term to make things really work well.
Thanks again so much. And I'm going to give you one last one for this section before we go on to hear from some of the societies and their perspectives on these issues. But one of our listeners said that, what do you think about the idea that there's a fifth level in your framework that would look at EHR functionality implementation and optimization? And would that, do you see a role for that as an expansion of your current model?
Yeah, I think, I think there's probably several levels of expansion to the model. I think some of the, we were taking more of a practice-centered view when we were thinking of the model, and it was really thinking about, on an individual practice level, how do we think about this? But there's even, a broader level of how it fits into the broader health system, and how functionality supports not only that practice but the care delivery system. And so I think in that context, I think that sort of understanding the different layers of implementing and the different layers of changing health outcomes through health information technology, I think that's a whole research area that needs more development and more focus as well.
Terrific. I was actually noticing myself on the diagram, and if folks don't remember it, there's a bottom loop that says, that you all put in, that says as you're improving things, you loop back and you look if it's not improving, and you reassess and you improve. And maybe that's also some of the optimization work, so maybe that was capturing it as well. Oh, here it is. So if outcomes are not improved, and maybe even if they are improved, but we want more improvement, we just need to reassess and go back. So maybe that's that optimization loop. With that, though I want people to see the screen, if we move forward, I've got some pictures of our next speakers who are very glad are able to join us. The first speaker, Jason Mitchell, actually, unfortunately, from the American Academy of Family Physicians, is not able to join us due to a sudden conflict, but his presentation is going to be covered by his colleague, Bob Phillips, who I'll introduce in a moment. So the first speaker who is here is Christopher Lehmann. He's a professor for pediatrics and biomedical informatics at Vanderbilt University. He conceived and launched the Journal of Applied Medical Informatics, which is devoted to original research and commentary on the use of clinical informatics in the day-to-day practice of medicine. And he has served as its editor-in-chief since its inception. So a perfect person to respond to our presentation today. He's also served on the board of the American Medical Informatics Association, and in 2010 was inducted as a fellow into the American College of Medical Informatics. Dr. Lehmann is the medical director of Child Health Informatics Center for the American Academy of Pediatrics, and serves on the examination committee of the American Board of Preventive Medicine's Subcommittee for Clinical Informatics. Speaking for the American Board of Family Medicine and doing double duty with the American Academy of Family Physicians today is Bob Phillips. He is the Vice President of the American Board, where he guides research efforts related to the maintenance of certification, continuous quality improvement, and improving the health of the public. He's a professor of family medicine at Georgetown University and a member of the Institute of Medicine of the National Academy of Sciences. And wrapping it up for us today is our colleague Jim Mould, PBRN stalwart, and also the George Lynn Cross Professor and Director of the Research Division in the Department of Family and Preventive Medicine at the University of Oklahoma Health Sciences Center. He founded and now a member of the Board of Directors of the Oklahoma Physicians Resource and Research Network, or OKPRN, a large regional primary care practice-based research network. He has substantial experience in primary care practice-based and implementation research, pioneered approaches to re-engineering primary care practices to improve the delivery of evidence-based preventive services efficiently and economically, including the use of academic detailing, practice facilitation, and identification and spread of exemplar practices. Most recently, he has helped champion the creation of the National Primary Healthcare Extension System to support continuous quality improvements in primary care practices and greater support for community health initiatives. In 2008, he was elected to the Institute of Medicine as well, and has been the author or co-author of over 130 peer-reviewed journal and articles. So, gentlemen, I turn it over to you for your comments.
All right.
Wonderful. Thank you. Thank you, David. I will do my best to fill in for Dr. Mitchell. So Jason, Dr. Mitchell was keen to get this idea on the table up front that technology is a tool and not the answer. That technology can facilitate a lot of these functions that we want to achieve both in primary care and meaningful use, but just having it is not sufficient, that we actually need to make sure that it fits our workflows and that it's being used appropriately. In fact, sometimes we wind up developing these technologically walled gardens that we have different EHRs, and we're even using them in different ways in different settings so that we can't share information and can't more appropriately coordinate care. In fact, some of the early studies of quality improvements where they compared electronic health record practices with those still using paper-based mechanisms found that the paper-based systems actually provided better quality improvements and outcomes, again, mostly because of the divisions or the siloing of the information across different providers and settings. And the third bullet, that care teams and care plans must be comprehensive and continuously managed, means that we have to be able to use the data in the context of workflows and new team functions to use the data effectively, do the work about team work and caring for patients. Again, just having the data and having the technology is not sufficient to make care management happen effectively. And finally, the population health management, it needs to drive towards individual care and outcomes, not just about improving costs or utilization or even population health outcomes if it is not also done in the context of driving improvement at the patient level. So, for example, handing a physician a quality dashboard from their aggregate data is not sufficient if they can't actually actualize improvement for each patient where their quality metrics are falling down. So it really means that we have to be able to turn the data into population level measures, but also be able to use them at the individual patient level and also potentially at the level of decision support at the point of care, so that the data are actually affecting the decisions we're making and guiding the care we deliver with the patient immediately in front of us. So I think those were Dr. Mitchell's key points for this presentation.
All right, I guess that puts me up. This is Christoph Lehmann. Good afternoon. If I could have my first slide, please. Thank you. So, as you heard, I'm the medical director for the Child Health Informatics Center of the American Academy of Pediatrics. And as a primer, I would like to share with you that the AAP is a strong supporter of the use of health information technology and electronic health records, because we believe that they can improve quality, reduce cost, provide safe and effective care, and we believe that only the use of electronic health records will truly implement the medical home, which the American Academy has been advocating for since 1965. At the Academy, the health information technology is led and supported by two leadership groups, the Child Health Informatics Center, which I'm representing here, and the Council of Clinical Information Technology that has over 500 members, and I looked at the attendee list, and I recognized a whole bunch of names, and I'm very glad to see this strong interest. Next slide, please. So obviously, the model that Dr. Krist explained here, looking at how electronic health records are supporting the primary care, is something that the pediatricians have great interest in. Unfortunately, this paper only appeared this year, so it's hot and off the press, and we have not been able to use it in our recurrent periodic surveys of our membership. I thought I'm going to use my 5 minutes here to give you a little bit of a snapshot of what we think the situation of electronic health records is out there among pediatricians, and think about how we're going to incorporate this new model into our survey going forward. We've surveyed our membership on EHRs in 2009 and 2012. And so these data actually are fairly hot off the press. It takes a while for us to analyze them fully. What I can tell you is electronic health record use has increased to 89% of pediatricians, office-based pediatricians. But what is very interesting to us is, other than the 21 who are not using electronic health record, only 14% are using what is considered a fully functional EHR, and 31% are using a basic EHR. So what's a basic EHR? It has patient demographics, problem lists, medication orders. You can view the lab results and the imaging results. You have clinical notes and medication lists. Fully functional have other features, and I'm going to refer you to the literature. There's a Roche article in the New England Journal of Medicine that describes it. It has another bunch of features that are considered to be included in EHR to make it fully functional. We have to, and I think after this paper and this presentation, I think we have to reconsider how we're going to survey our members going forward, because the primary care aspects are not really well addressed in this existing model that we use for the survey. But going to the next slide, if you look at, next slide please. If you look at the, hello? May I have the next slide please?
It should be on the next slide.
Okay. I don't see it, so I'm going to go ahead and pretend you are seeing it. When we go even further and look at functions that we consider essential for pediatrics, and that doesn't mean they might not be necessary, they might not be helpful in adult medicine too, but looking at functionality that is truly critical for practice of medicine in children, like weight-based dosing, tracking of child visits, immunizations, immunization forecasting and catch-up, plotting growth charts, and computing height, weight, and BMI, you will see that the number of EHRs that are in use out there is negligible when it comes to people that have all these pediatric functions in place. Going on to the next slide, that should say basic and fully functional EHRs are not used by small practices. What we discovered is that we have a big discrepancy of people who are actually able to use EHRs. The larger the group is, the more likely they are to implement them, and clearly our smaller groups that are being left behind when it comes to using basic or fully functional electronic health records. So there clearly is a need to improve the quality of the electronic health records. We will reconsider our survey based on what we have heard today, on a model that thinks more about the delivery of primary care, and hopefully we'll have some more data to you in a couple of years. Last slide, please. The one thing that we also were serving our members on was the data exchange, because we think it's incredibly important for the integration of care, and I thought this in the context here was interesting. This is capability. This is not actual exchange. This is having the capability of exchange. And you can see the capabilities are pretty good when it comes to immunizations and claims, but when it comes to things like reportable conditions and surveillance data, capabilities drop off to very small numbers. So clearly there is a lot of work to be done, and there's a lot of need to improve electronic health records. One of the questions that we received in advance of this webcast came from Mary Tierney. She asked to comment about pediatric functionalities and EHRs. One of the things that I would like to refer this group to is to some wonderful work that AHRQ supported and conducted. The model pediatric EHR format it is based on some functionality requirement that in HL7 started, and this project substantially extended on functionality. Again, it doesn't keep this framework in mind, but it is quite extensive, has over 600 requirements for the pediatric EHR format, and you can access it at the United States Health Information Knowledge Base, where it has its own section, and you can actually go and look at the format and drill down in it. And that concludes my section. Thank you.
Wonderful, thank you. So this is Bob Phillips again talking about the certifying board perspective on electronic health record functionality. Alex, if you could advance the next slide. So family medicine now is about 83,000 diplomats, the second largest medical specialty board, and we now routinely survey them as they come in to fill out their demographic data, so it's a 100% response rate. And we have built out a series of questions based off of the NAMSIS, the National Ambulatory Medical Care Survey questionnaires about needs functionality of EHRs. We piloted this now 2.5 years ago and found that about 75% of our diplomats are using electronic health records, but similar to Dr. Lehmann's presentation, just slightly over half of those were able to comply even with Meaningful Use 1. So a lot of them are facing either retrofitting or rip out and rebuilds of their EHRs currently to try and move ahead in terms of functionality. We also have an issue where a lot of family physicians and physicians in general now are being asked to report out measures or data either to their own organizations for maintenance certification or PTRS, and there's a real need to make sure that our electronic health record systems can actually reduce that reporting burden by making it easier to report, and also that the different groups receiving the information, there's some consistency across what's being requested. And we have a real urge and need to turn our data into actionable information. And that means for maintenance of certification, being able to use our data effectively to assess quality of care and what we do to try and improve the quality of our care. It's surprisingly hard with many of our EHR systems to actually get out that basic information. We need to be able to look across our populations, and it can be as simple as creating registries of our patients with certain diseases, but even more it can be about trying to construct ideas of service areas and penetration rates of populations, constructing community vital signs, drawing on social determinant data linked to the addresses of our patients. So there's a lot to be done in that area. And then finally, under actual information is just the capacity to use the data for decision support, particularly at the point of care. And right now, much of our data lies dormant in that regard. One of the things that we've identified that would be helpful for that, at least in primary care, would be moving to a domain-specific classification system called the International Classification of Primary Care, which would actually help the move to ICD-10, because this classification system has been mapped to ICD-10, and it can facilitate, while coding in our system, the ability to identify ICD-10 codes that correspond in a very easy fashion. It's constructed in a way that you can actually make episodes of care from the presenting symptoms all the way to diagnosis and outcomes that you guys track over time. And our Dutch colleagues in particular have used this quite effectively to understand episodes of care beyond what the United States typically looks at, which is a one-year time period. But we know most conditions can span many years or be episodic. And the Dutch have also taught us, using this system, that it actually turns your patient database into a Framingham-like decision support tool, because it starts to give you pretest probabilities of what someone with a certain age, demographic, symptom may be experiencing and what the test you should be using to rule out important things and to rule in the most likely things can be very helpful. And finally on this slide, we need better measures of primary care, and that is that most of the quality measures that we're reporting on right now are disease-specific and really don't address the functions of primary care very effectively. Barbara Starfield, before her death, was actually developing several of these tools with others in the United States and internationally. You just need to find ways to effectively integrate those into our EHR systems. Those data are collected. Next slide, please. Alex, thank you. And some of what I've just covered, we actually had developed as recommendations in a conference report from 2007 that was supported by the Agency for Healthcare Research and Quality called Harmonizing Primary Care Clinical Classifications and Data Standards, which actually involved several people from other countries and WHO giving examples of how other ways of organizing data, capturing them, and using them can inform U.S. systems of meaningful use. And that report is available online at the Robert Graham Center, should anyone care to look at it. Thank you so much.
My name is Jim Mold, and I'm from the University of Oklahoma. I'm a member of the North American Primary Care Research Group, or NAPCRAG, NAPCRG, which is basically www.napcrag.org for those who want to look it up. I'm the immediate past president of the Committee for the Advancement of the Science of Family Medicine, and I'd like to talk a little bit about EHRs and primary care research. Next slide. So we're coming full circle back to the attributes that the Institute of Medicine articulated as a definition for primary care. I'll point out to you that primary care is the only area within medicine that's defined by processes rather than by content or by patient population. So these attributes essentially define the discipline of or the function of primary care. So when I was the chair of the Committee for the Advancement of Science of Family Medicine, one of the tasks that we took on was to look at why primary care produces better outcomes. We know because of the work of Barbara Starfield and others that in fact it does produce better outcomes, and we articulated those outcomes on the right side of the logic model that you see in front of you. We then looked at the attributes on the left side, and we said, how do we get from those attributes? Why do the attributes lead to better desired outcomes? And so we did a systematic review of the literature, and we created a draft model, and we sent it out to experts for their input and so forth. And this is the current version of the model. I say current version because I think it can still be improved, but it serves to illustrate my points that attributes lead to outcomes through a set of mechanisms. And there are always intermediate outcomes that are usually easier to measure than the desired outcomes, so we wanted to include those in the logic model. Next slide. So this is just to show you how complex this is. If you just take one of the attributes, that is partnership with patients, and you draw arrows to the mechanisms that through which that might work, and then you look at, from each of those mechanisms, you look at what intermediate outcomes might be affected by that mechanism, and then you look at, from each of the intermediate outcomes, what desired outcomes would lead from that. And this is just from one of the attributes. You can see how complex this is, and it illustrates, if you drew in all of the arrows, it would illustrate the point that all of the attributes are essential and that they all work together. Much of the research that's done in primary care these days, and much of the research that needs to be done in primary care, has to do with practice redesign. How do we do a better job of delivering these attributes functions or these processes so that we can get better outcomes. The reason to present the logic model today is that I believe, at least, and the people that developed the logic model believe that it would be very helpful if we could embed measurement of as many of these boxes as possible within EHR systems, because in the future we're not going to be able to we're not going to usually be able to design randomized controlled trials or pragmatic trials. These changes are occurring as we speak. We can't stop the train. We have to study things as they evolve. People are innovating all the time. It would be nice to be able to have a standard set of measures that we can go back retrospectively and look at to see whether a particular change, such as teamwork, how that's reflected through the model. One might expect that teamwork, for example, might increase accessibility, but on the other hand, it might decrease satisfaction with care. But we don't know, and there are always trade-offs, and so this sort of a model, and maybe this is more complex than it has to be, but this sort of a model might guide EHR developers to figure out ways to measure not just the attributes, but also the outcomes, and as many of these intermediate mechanisms and intermediate outcomes as possible. And I think that's all I want to say. I think the questions will bring out more of the points that I could make.
Well, thank you, Jim and Bob and Chris. Lots and lots for people to think about. That's exactly what we were hoping. So I'm going to ask folks to start putting in your questions. We have a whole bunch of good ones already, so gentlemen, get ready. I'll start with a simple one for you, Bob. Somebody asked where they can learn more about the International Classification of Primary Care. Do you have any quick resources or places to direct folks?
Certainly. Just Googling International Classification of Primary Care will get you there. If you pull up the conference report that I showed online at the Robert Graham Center website, Chapter 8, the last chapter, is a very good walkthrough demonstration of the utility of the classification system by the Dutch. And there was a special issue of the Journal of European General Practice in 2010 that was completely dedicated to the use of ICPC and the different kinds of research and population-based measures that it can support. And if anyone emailed me, I could send them a link to that if they'd like.
Oh, terrific. Thanks so much. So here's a really broad one that anybody is welcome to take. You've identified a lot of functionalities and a lot of needs for us to make a better system and get those functioning systems to all of the primary care community. But given that this talk was started by a group of researchers, do any of you want to put forward what you think are not the highest priorities for EHRs, but the highest needs for research? And how can we prioritize the research needs so that funders will direct funding while the policymakers and EHR vendors and community are improving the systems?
This is Alex. I'll speak first, and actually in answering this, I'm going to try to channel some of our the HIT committee's conversations, and I mean, to start with, it's important to know it's kind of it's one of those conversations where lots of people have lots of different opinions on this. And I think trying to objectively say what do we need the most and where should we start is difficult. And to some extent, where we need to start also sometimes is locally defined because different people can do different things. Some of the common themes that come up among our discussions, though, quite simply, one is getting clinicians and researchers access to their data. So a lot of folks who want to look at outcomes and track things aren't able to just pull that information easily out of their electronic health record. And I remember when my practice in 2004 bought our electronic health record, we were asking this question, and the vendor said, well, it's just a SQL database. It's really easy to get. But it isn't. That's not how it works. So that's one issue. Another issue has to do with sort of standardization of the data. So even folks who can get access to the data, making sense of it can be a difficult thing. So that's another common theme that comes up. A third common theme from a research standpoint that comes up is from the folks who want to do interventions. And in the context of if they want to do an intervention that involves their electronic health record or their patient portal, and they have a commercial system, they're often bound to the constraints of that system, and it's difficult to do things that are outside of the scope of what that system normally does. And so some of our members complain about that hindering their ability to create new innovations and integrate it into their system and field it for their clinicians and for their patients. So those are three common themes that have come up with our team's discussion. Others might have other input as well.
This is Jim Old again. It may be the most difficult area to approach, but it's the most important, and that is how to help us be person-centered. Current electronic health records are not. They're basically disease-oriented. And it may require decision support systems attached somehow to the current electronic records, perhaps through health information exchange systems, because I don't think, you'd have to pretty much throw out the current system and start over to make electronic health records themselves person-centered, or to make them compatible with person-centered care. But perhaps the answer is decision support systems attached to EHRs somehow.
Keep going.
This is Christoph Lehmann. I just again, I think both of those comments were great. I think I agree. There's one thing that I would like to add to this mix is, there are a lot of things we can do with health information technology to remind providers to do the right thing at the right time, but there's a limit to the amount of things that can be done within a visit. So one of the things that I would say is should be a prime target for research going forward is how much can you put into an office without visit without overloading the primary care physician, and more importantly, which of the interventions that we can do are the ones that truly provide a bang for the buck. So to give you an example, we tried to get primary physicians to monitor labs for certain drugs, and even though we did a significant intervention, did a lot of reminders and a lot of impact, we were not really very successful in improving in the quality of labs. So the research that we need is which interventions work and provide you value, so we can pick the best ones to implement in our systems.
Okay, taking in a slightly different direction, somebody wanted you all to reflect on, do you think can you point to exemplars or innovators or products right now that are really making progress in the domain that the report showed of supporting population health management in primary care? People want to learn more and see how this can be done. Are there places to point to them on population health management using EHRs for primary care?
If I may jump in, this is Chris. I would like to put in a plug. The American Academy of Pediatrics has an EMR review site where pediatricians answer questions about the EHR, and there are a number of categories on functionality and what the EHR does. This review side, while it's not yet aligned with the primary care principles, is, I think, for pediatricians a good start.
Terrific. Anybody else have resources on population health management in EHRs?
So Jim, we have actually done some of, we've been working in the direction that I suggested we needed to work, which is we have a preventive services registry, which is comprehensive, includes primary, secondary, and and tertiary preventive services, and is connected in one of our counties to the Health Information Exchange System, so that when practitioners open up their EHR, they have a tab that connects them to the Health Information Exchange System, and then it connects them through another tab to a list of the preventive services that are due on that particular patient. That can be, and the next step that we're going to take is to separate that from the encounter, so that basically registry managers can remind people of when they are due for their preventive services using that registry that collects information not just from the electronic health records in the practices, but also from the hospitals, emergency rooms, public health system, and lab database.
So Jim, where can folks learn about that? Learn more about that? Is it on your website or?
Well, there's several we published some. Schultz Nagakali has published a number of papers on this. I think if they go to www.okprn.org, which is the name of our practice-based research network, and look under the publications, which would be, I suppose they'd probably be under implementation research. They're categorized by what type of research it was, but they should be able to find those publications.
That's a great start, and we'll try to send out that link for everybody as well. Okay, another question. So do any of you know of any research, or was it actually talked about in the paper? And if the answer is no, please say it, but one of our listeners asked, that actually is starting to look at which of the different functionalities and domains and specific gaps that you identified have been shown to make significant changes in patient-centered outcomes. Is there any knowledge about that so far?
So this is Alex. In response to the paper, no, we don't have a whole lot of linkage to the outcomes. And if we think about the meaningful use roadmap, stage 3 as a nation, which we're not at yet, is supposed to be looking at improved outcomes. I think that there are a good number of studies that are being done with information technology around very specific interventions that are showing improved outcomes. AHRQ's safety portfolio, we've done some work within our team around patient portals and promoting preventive care and demonstrated increased delivery of recommended services. And that's actually on the AHRQ Innovation Center, which is another good resource for finding out some things that are going on, or the Innovation Exchange, to find out things that are going on around this. So I think from in developing this, the model and the framework around applying these meaningful use elements to the primary care attributes, we didn't see a whole lot of outcomes around that framework, but there's lots of specific intervention examples and innovations that are occurring in research networks and in health systems and other settings that can be plugged into those attributes that are beginning to show improved outcomes.
Thanks again.
This is Jim Moll. I would just point out that most electronic health records don't contain outcomes. I mean, they contain intermediate outcomes at best, and I guess we're going to have to connect to other sources of information like public health information, and we're going to have to add sections to the record for quality of life and so forth. They're not there. The actual outcomes are not there.
Which might head us back to the earlier question of what are some of the research gaps that we collectively need to start addressing. this may be similar, but again, just giving you all, in case you've seen examples of this that you want to highlight for folks. But in the framework, there were some, towards the end, was the discussion of the interest in, from primary care functionality, the need to connect with community organizations, the public health community, as well as community-based organizations. So two questions emerge from that. One, do you all know of folks, have you seen the public health community and the community-based organizations? Are there receptive partners there who want to use electronic health records or information systems to do this linkage? And have you seen any examples of places where primary care communities have been connecting themselves and trying to improve health by using health information exchange or EHRs to make links with either the public health or the community-based organizations?
This is Jim Moe. We're beginning to do that. I think there's a lot of work to be done with regard to how to analyze the data, how to put that together with public health data, and how to integrate that with the county health improvement plans that the CDC is requiring. So we've started doing that, trying to figure out what the data should look like for decision making at a county level, and we're also putting together primary care and public health folks with other community organizations within county-based 501c3s. So it is happening. We're not there yet.
David, I think OCHIN in Oregon, which actually works across 15 states, and I know has been one of your grantees, with the new PCORI funding that they've just gotten, is going to be, besides linking a whole host of safety net practices in hospitals to share data, they're going to be pulling on social determinant data to create community vital signs for patients and to identify public health and other resources in the communities that could be further support for patients and population health.
Great resources, and I had not thought of this in advance, but I'm looking at my screen and I saw that Kristen sent out the link to the Innovations Exchange that Alex mentioned earlier as a source, and there's actually a whole community on the Innovations Exchange about linking primary care, public health, and community, and I don't know right now if there are things about using health IT, but it's another source folks who are interested in that question might go to. Couple of small information things our audiences wanted to share. One of our colleagues suggested that folks who are interested in thinking about how information technology can move into the patient sphere might want to look at how the group Patients Like Me at patientslikeme.com is developing a research agenda about functional outcomes that matter to patients and how to report them and record them and capture them and show how and track them along with health and health care. Sorry, I'm just trying to scan these as they've come in. Some of you are doing great work, and I'm going to encourage you to join our PBRN listserv to let folks know specifically about that. Some folks have mentioned that there's some very innovative work happening through CMS and the Innovation Awards, as well as the SIM grants, where people are trying to tackle some of these issues, along with health information exchange, population health issues, including one in, I believe this is Missouri. As we're closing in on our time, I actually would love the presenters to give us their thoughts about if people on this call wanted to continue this dialogue, wanted to understand your paper more, or the research agenda, or the policy agenda, or hear what people are doing to address these gaps, are there places that you would recommend they go to continue the dialogue?
This is Alex, and I'll jump in. The NAPCRG Health Information Technology Working Group is open to anyone who wants to join, even if they're not a member of NAPCRG. That would be fine. So people can email me about that. There is a listserv through the PBRN. We could use the PBRN listserv to continue the discussion as well for members who are on the PBRN listserv.
Thanks, Alex. Anyone else have some places?
Yeah. This is Chris. There are two places for pediatricians. I would recommend the Council on Clinical Information Technology mailing list. And then another good place is the Clinical Information Systems Working Group at the American Medical Informatics Association.
Terrific. And with that, we're just about at our closing. I will turn this over to Kristen in a minute. One of my greatest disappointments about webinars is that the presenters who've done such tremendous work can't hear that round of applause from the, we've had over 300 folks on the call with us for most of the call today. It should be a thunderous applause, so I want you all to imagine that and that I'm clapping as well. On behalf of AHRQ, our PBRN program, and all of us who've been listening to you today, thank you so much for the stimulating conversation. And Kristen?
Thank you, Dr. Myers, and thanks to everyone for attending today's AHRQ PBRN webinar. This live activity, electronic health record functionality needed to better support primary care, has been reviewed and is acceptable for up to 1.25 elective credits from the American Academy of Family Physicians. To obtain CME credit for participation in today's webinar, please complete the online evaluation of this webinar. You'll be prompted to do so when you exit the webinar. And if you would like to request a copy of your CME Certificate of Participation, please email pbrn@abtassoc.com. Please stay in touch with us by joining the PBRN listserv. Listserv members receive a biweekly digest and other announcements of interest to PBRN. You can join the PBRN listserv by emailing us at pbrn@abtassoc.com. Thank you for attending today's PBRN webinar, and thank you again to our presenters and our moderator. Please visit the PBRN website at pbrn.arc.gov for more information on PBRN webinars and events, and please email us at any time with suggestions for additional webinar topics. Thank you again, and this concludes today's webinar.